this case was, as mentioned, this is my disclosure. And this is the case actually we wanted to show you. It's a 71 years old type 2 diabetic and chronic kidney disease with high BMI of 34 with a history of angina CCS class 3 with occasional dizzy spells. The clinical examination is unremarkable. And his echocardiogram showed normal left ventricular functions, and ECG shows non-specific T waves, no Q wave or previous infarct. So this is the history of the patient. And as you can see, this is the right coronary projections, and you can see very clearly complex calcified bendy RCA. And so my first question from the panelists, this is the, sorry, before I go for the question, this is the left coronary system that shows mild to moderate plaque disease, but it's not flow limiting, and it's probably not the culprit lesions causing angina. So coming back to here, now my first question to the panelists would be, what are the possible challenges and complications before you take up this case? Any volunteer or General Suhail?
Hi Mohammed, it's me, Suhail Aziz. Great talk. Loved every bit of it. We have with us Dr. Shafkat Gurgulu from Turkey, and he'll be our point man for answering all your questions. So, Shafkat?
Right. So my question, please understand, my question is, what are the challenges and complications if you undertake this case?
So this seems to be a very difficult case, and if you see angiographically from the calcification there, it's for me severe calcification there, and you might have difficulty even bringing down the wire. And by probing the wire, you can understand whether this calcification is manageable or not, whether you need other wires like polymeric wires, or whether you need a microcatheter or something like that. And my first approach would be bringing a wire down. If I can bring the wire down, then I would probe with the IVUS, especially with the Boston IVUS or with another IVUS. And if the IVUS cannot go down, that means I am in real trouble, I need rotablation. So then what I would do would go with a microcatheter down, change with a rotawire and rotablate down there, and then begin to modification of this lesion. So we will not know what this lesion will entail without beginning the procedure. So sometimes it's very difficult even navigating with a wire, and then you can see that the wire is sticking somewhere, it's not coming, it's not moving, it's not going forward. And if you have difficulty in forwarding the wire, then it means you might be in real difficult
Thank you, Dr. Gorogu. Can I just stop? Because we have more questions which you are answering in advance. So very good actually points. And this is the actually, you can see on the right side, you see the guide sport is the first challenge, I think, because you need to cross many things, you know, across these lesions and bendy things. So, and secondly, as you have already mentioned, there were always very difficult crossing. I remember one patient with NSTEMI, where STEMI, and they wanted to, you see, cross the wire, and even the wire didn't pass through, and they just abandoned the procedure. So, and then same thing, we will face difficulty in crossing other hardwares like balloons, IVUS, rota, stents, and the complications is dissections and perforation. Now, my next question is strategy. You have already mentioned that you will have difficulty, you see, in the beginning, and you are very well actually said. And now guide sport, of course, Professor Egret chose to use implants guide. There is a 3D guide also, which is not exactly the same as what we call Williams catheter. It's a similar, invented by Professor Mazhar Khan. He's late, but somehow it couldn't come in the market. It gives excellent support. But anyway, this is about the guide. Then the wires and microcatheters, venous access for TPM. How many of you will use the temporary pacemaker or the venous sheath amongst the panel or any audience? Pacemaker.
If you keep your runs short, you know, the chance of pacing might be less. And if you do need it, you can sometimes use the guide wire, you know, shave off the proximal portion, connect it, and you can still pace with the distal wire.
Would you do or would you not do pacing?
You know, in worst case scenario, I would scrub the groin and be ready for it.
Okay, that's
but,
good.
You know.
All right, so stand by TPM. What do you say, Mohanad? You have done so many cases rotablator with complex RCA. Do you use the temporary pacemaker or not?
I think it's been about 9 or 10 years since I put the pacemaker during rotablation. Very, very, very rare. It's important to kind of choose the size, the correct size, and even if you have the small one and upgrade, that's probably easier. And you take your time because you could test the artery and see how the patient is going to respond. If they go a bit bradycardic, you don't have to be using the burr for 20, 30 seconds. You do it 5, 10 seconds and let the artery, drink some blood, and the bradycardia will resolve quickly. So it's been a very long time since I used the temporary wire.
Okay, thank you. And the others, as we already mentioned, we will need IVUS, OCT, or cutting balloons or the NC balloons. Now, this is the problem. Professor Agrid had to struggle, you see, to pass the wire. He started with NC, that what we call cyan blue wire, that didn't work. Then he changed to some wriggly wire, and then ultimately he managed to cross the wire using this crosshair. Now, these are the 4 probing catheters which are available in the market. Fine cross is the traditional, when we were training in Guy's St. Thomas's, they used to do fine cross, but it is straight. The others are crosshair and Ventura. Mohanad, can you tell us is there any advantage? Because the problem doing practice in Pakistan is that, you see, the cost is a very major issue. So can this kind of lesion be, negotiated with simple balloon sport or maybe microcatheter? What are your experiences?
I mean, obviously, particularly when you're thinking about the economical constraint, there's always nothing easier than a balloon and a wire and a balloon. But you have to be thinking whether you're going to need any debulking. Of course, in this case, you could take a small balloon, and often this is what happens in the majority of places. You put the wire down, you start by taking a small balloon, 1.75. This is the smallest we have nowadays. You increase the balloon slowly. If they are responding, you might get away with the balloon. If not, then you'll have to be thinking about debulking. However, for the microcatheter, I think Corsair and the likes, i.e. with the cone tip that you could spin and allow them to go through the lesion, to my mind, is much more effective than the blunt tip like the fine cross or the Brunavi, because the fine cross, you cannot spin them and they could get stuck, while the Corsair, the Turnpike, the Elong, you could spin them and they'll be able to go through the lesion and allow you to exchange your wire. So if I were to have only one microcatheter, I would choose one with the cone tip.
Okay, thank you.
Can I ask Shafkat,
Sure.
what would your preferred micro be for this situation?
I totally agree with Mohamed. So I use the Elong 2.6. It's a coiled microcatheter, so you spin them down, and it's also very resistant to calcification. It's definitely 2.6 French. You can use a Turnpike spiral as well. There's the outside with the outside coils, but definitely a coiled one.
Thank you. So this is the first challenge that we crossed, and see, using these microcatheters, and Professor Agrid explained to you about this.
Soil is reminding me of something.
Okay.
So if you use the Corsair or the Turnpike, you have to be very careful not to overspin it, okay? If you see that the tip of the microcatheter is smashing or it gets squeezed, you can leave that proximal part in the lesion. So you have to be very careful by doing that.
Okay, thank you.
Shafat, sorry, that's a very, very good point, really important, because these cone catheter have got a welded tip. And if the tip is stuck in the calcium, it's not moving, you keep spinning, the tip could easily break and could be stuck in the artery. So it's really important to make sure that it's moving and you're not really overspinning if it's not advancing that much. And if that's the case, you could try to take the normal wire out and see if you could deliver the rota wire or the orbital wire down. But do not, if the tip is fixed and not moving, don't keep spinning because you could break it.
Right. So the next step, as Dr. Korgulu, he mentioned that, we need to prepare the lesion, or take the pictures before we prepare the lesion. Nowadays, imaging is very important. But the problem in this case was the IVUS probe wouldn't go, and Professor agreed, then he probably just make a decision to use a small rotablator bar, and although it was not easy to pass through the lesions, but I think he managed to do it. It is 1.25. But Mohanad, one question from you. What is the rotation you use, using this, or do you want to upgrade it? If it doesn't cross, what will you do? We will increase the revolutions, or you will to step up the size of the bar?
Um, Thank you. I think the first thing to say, I very often, not very often, use 1.25. In cases like this where it's quite resistant, severe tortuosity, when technically it's a relative contraindication to rotablation, but if you use the small burr and you do it gently, you should be okay. And I often will use, maybe in 99% of my cases, I use extra support rota wire. It's particularly in such a case with tortuosity. The burr or the rotational number probably be 175 to 180 for the smaller burr, 1.25 or 1.5. If I'm going to the bigger burr, 175 or 2.0, then probably I'll be a little less aggressive, probably go 150 to 160. If this small burr is not going upgrading to a bigger burr is not going to allow you to do it. All what you need to do with rotablation is just to be patient. If there's a lot of calcium, you need to take your time. And that's kind of something most interventionalists don't have because all what we want to do is just do it quick and finish. But for the rotablation, and if there's any resistant lesion, take your time because also trying to rush it and push through, this is why sometimes you get the burr stuck. I always say if the burr stuck is the operator fault, nothing else. So take your
Okay, thank you.
time and just spend a long time to be, even if it take you 5, 10 minutes, it's not an issue. Take your time and manage to modify this calcium.
Yes, we agree that you see the 1.25 bar is usually not used, but in this particular tortuous lesion where 1.5 bar can cause more harm rather than good. All right, so this was the result of the IVUS results of this first rotablation. As you can see, there are fractures of calcium on 1 o'clock, and if we just move this, there is still a lot of calcium you can see in our pictures, and in some of the places, although there are many ruptures, but there are still 360-degree calcium in some of the places. So now the question is what to do next. Professor Gorgolu, what would you do next?
So normally, after doing the rotablation, I will further modify the plaque. My preference will always be long NC balloons, and preferably a scoring balloon, the wedge NC I'm using a lot. So it's a non-compliant balloon, it has a wire over it, and it's an NC balloon at the same time. So I would further modify the plaque to open the lumen a little bit more. Cutting balloon, if I had a cutting balloon and the most stenosed part, I would also use it, but preferably I use the scoring balloon.
All right, thank you. Now, what happened was
Okay,
after
can I
this-
just, sorry,
Oh, yeah, sure.
Afsar,
Yeah,
just
go
one thing to say. If you're doing an IVUS, one of the things you'll be looking for is this reverberation in the IVUS. The reverberation on the IVUS tells you that calcium has been affected and has been thinned. And that's quite an important thing. If you look at the IVUS we saw, and in cases like this, I mentioned when I was giving the talk, that when you're doing a rotablation, it's important to make sure that you really size the burr correctly so you affect the calcium and the vessel. Occasionally, like if you know you use 1 to 5 and you find the calcium is broken, there's reverberation, which means it's thin, then fine, you could use the balloon. But if it's a bigger vessel, it's better to upgrade. And I understand the economic argument and the cost, fair enough. And if that's the case, you probably start with the bigger burr to use one. But often you probably end up having to upgrade the burr to affect the calcium more. But if the IVUS shows you reverberation, that means you probably have affected it.
Thank you. So what the problem was, we were unable to cross the balloon. So here comes a very important device. I think it's the guide extension. So in this particular case, it was impossible to pass either wire or balloon or any stent. So we had to use the guide extensions. And with the help of guide extension, you can see that the balloon is still impacted and spiral shaped. That means the hardness of the lesion. And these are the different guide extensions. Now, just a quick question for Professor Agrid. Can you tell us about guide liners? We have guide liner and guide Zula. The problem is the cost here in this country, and they are in different French. Why they are different sizes? Can you just give us some, educate our trainees and others? What are your experience about guide liners, its complications, and the size of the guide liner?
Yeah, I mean, guidelines already have been a revolution. We say guide extension, really, in general. Guideline is the name that was given the first
extension,
time.
yes.
Yeah, it's absolutely revolutionized our procedure. As you know, the majority of our procedures happen with 6 French. So it's important to have something that's compatible with 6 French. But of course, some procedures happen with 7 or 8 French, and that's where the sizes come differently. The thing with the guideliner, the complication that might happen, delivery can be a little difficult in cases where you could use the inchworm technique by putting a balloon and just slowly advancing the the guide extension. That's one thing you could do. And when it's down, you really have to be careful. First of all, your pressure could get really blunted. So again, you have to kind of let your technician or physiologist know because they get really edgy and scared. As long as you're happy with the clinical condition, it's not an issue. When you're injecting, it's very important to make sure you don't go gung-ho and inject the as normal as you do with guide catheter because you're down into the artery in a very kind of a restricted space. If you inject hard, you could cause perforation or dissection. And yes, you could. One thing to do if you're struggling, particularly with stents, is to deliver the guide extension a little bit beyond the lesion to be able to deliver the stent. Then you bring back the guide extension and put your stent in, because but it is a very good one of the best invention that changed what we do in intervention.
Does it cause any problem if we use some bigger balloon like 3.5, 6, and this inflated balloon can't come back? So in that case?
Oh, sure. I mean, you have to understand the inner diameter and the outer diameter because even some of the 5 French, some of the stents might not go through. And if you're dealing with calcium, also if you're using 6 French, for instance, some of the covered stent might not go through because you have to anticipate if there's a perforation, what am I going to do? Some even the current new low profile covered stent, if it is above 3.5, might not go through the 6 French guideliner if you have another wire. So really have to be careful. And this is where understanding your equipment and knowing what you're dealing with is important. You mentioned something about the size of the guiding. When I'm doing a complex case, I always go 7 French. And well, you could do it to 6 French. Of course I can. It's better to have your gun and not need it, or I need your gun and not have it. It doesn't cost me much to put a 7 French because if I need a body wire, if I need an anchor balloon, if I need the guide extension, it's much better to have the enough space to do that.
Thank you. And just 2 or 3 more slides, then we finish and go to the next one. So this is the we were thinking of using IVL, which we didn't, and we were managed to dilate the lesions with the first 2.5, and then, but this was not possible without guide liner, as you can see from here. This guide liner coming out, and you saw it was not possible without the guide liner. So we pre-dilated, and now you can see the lesion is deflated. And so after this, we didn't use intravascular. I will not go into the detail. You have already explained this, and this is the second last slide. So again, the problem was with the stent. The stent would not pass through. The balloon is dilated, everything, but with the calcium, the problem is there is either a spur or maybe nodular calcium or part which would not let the stent pass through. So guide liner, again, we use the guide liner, as you can see from my first slide. You see the guide extension up to here to deploy the distal stent, and then it will able to do that. This is proximal and distal, and this is the final result after the putting the stents. And you can, I will show you this post-stent IVUS. You can see that the stent is very well opposed and very well expanded. There is no gap between the stents and the wall. Here you see the imaging is important and useful, that you see the stent is properly deployed, and there is some indentation, but that is acceptable. So this is good results, and the final results, this is before and this is after. So it was a wonderful job, except there is a little dye which is probably a hematoma, and so this is all about. So take home message is always preempt possible challenges and complications. Number 2, we should do necessary homework to assess if we have acquired expertise and equipment. If not, such cases can be referred to a large volume center or request the services of a proctor for a safe outcome and to enrich learning and experience. And I thank you for your kind attention.